Hi everyone and welcome back. I am, I say this all the time, but I'm very lucky to have some very clever colleagues and friends all over the world working in women's health. And today's guest on Meet the Experts is absolutely no exception. I met Heather a bunch of years ago. We were trying to figure out exactly when, but I think we've known each other online longer than we've known each other in real life. Right. And Heather is a women's health physio in California, and she has 3 clinics in the Los Angeles area. And I'm going to read you just one of her Instagram posts, which really made me think that she would be the perfect person to talk to about today's topic, which is sexual health at menopause. So Heather's just back from teaching in Istanbul, and she says, she's writing here on Instagram that I'm traveling to Istanbul to teach a 2-day course for European physios on female sexual function and dysfunction. Pretty amazing. And just some interesting facts. The skin of the clitoris has a dense collection of nerve endings, 8,000 of them, which is about twice as many as your average penis. And erectile tissue of the clitoris engorges 50 to 300% its original size during arousal, and labial size increases 2 to 3 times its original size as well. But she goes on to talk about how female arousal is complex, and there's a little bit more to it than maybe we see in movies where, everybody, sex basically lasts about 30 seconds, everybody's having an orgasm at the same time and we're done. And nobody ever has an awkward conversation about lube or condoms or anything like that. So I really want to thank Heather for joining us today. And Heather, of course, is the author of this fantastic book that really no pelvic health physio should be without, Sex Without Pain. And we'll talk more about this book as we go on. So hi Heather, how are you?
Hi Michelle, I'm good. Thanks for having me on.
Honored to have you here. So what are your thoughts on sexual health at menopause? How can sexual health change as women are going through perimenopause into menopause and beyond?
Right. Well, that's the big key word that you said is change, because I really educate my women as they're going through that transition that they do have to consider change, that they can still have a very satisfying sex life, but they can't be doing the same thing that they were doing when they were 20. Okay. So they have to evolve their nightly routines to adjust for the fact that maybe their back might be hurting now, and how are they going to modify their position that they are hypoestrogen. So what are they going to do about that, and what does that mean? So they just have to modify what they're doing, and they can still lead a very satisfying sex life. They just have to get the right tools and education on board to continue in that direction.
I think that's a really interesting point, because we think about estrogen a lot at menopause. Of course, one of the euphemisms for menopause is the change. And it's kind of an appropriate name, really. So if estrogen is affecting all the tissues in the body, how is it specifically affecting sexual health?
So when you become hypoestrogen, you lose lubrication in the vagina. So what does that mean? If you don't have lubrication, things will be dry and probably painful. Loss of estrogen also reduces labial size and clitoral size. And so, smaller clitoris has been found to sort of linked to decreased sensitivity as far as arousal, and ability to orgasm. So there's that hormonal impact on loss of estrogen and testosterone, I should say too, because women have testosterone. It's not just about estrogen. So you do have a decrease in both of those when you hit menopause. And that's sort of maybe the initial, I'm thinking the active sort of intercourse and how that might be painful if there's dryness, but it'll also affect arousal and, just desire. If you have less testosterone, then even just your willingness to want to participate is going to, your sex drive is going to drop as well.
I think as well, a lot of the things that we're talking about in our third age menopause course are ways to kind of naturally balance hormones. And we know that, strength training, resistance training can improve testosterone levels and body self-image. And, eating foods, plant-based, estrogens, making we're eliminating some of those excess toxic estrogens as well, all go into effect. Do you feel that exercise and body image can play a role in menopausal sexual health?
Oh, completely. Yeah. I mean, and I've seen research to that effect as well. I mean, women that have a poor self body image tend to not be as, have as high of a sex drive and tend to report more dysfunction with sexual intercourse. So yeah.
And of course,
I
then
definitely
sleep disruption can also be a problem as well, because if you're not getting good night's sleep and you're tired, I mean, that's all going to play into everything.
Yes, of course. That was just out in like the latest issue of the Journal of Sex Medicine. Did you see that
Okay. No, I
article?
haven't seen it yet.
Oh yeah. So I'll send you that link. But that was in the latest issue of Journal of Sex Medicine on sleep disruption and its negative effect on sexual health.
It makes perfect sense, because if you're not getting a good night's sleep, you're really not in the mood for anything.
Yeah, exactly. And then if you layer the fact that you might have some pain on top of that, we know how sleep disruption affects chronic pain and feeds into that upregulated nervous system. So,
and of course, sleep disruption is going to feed into weight gain as well, which is going to negatively affect self-image. So it just spirals. Yeah,
exactly. It does.
Would it be fair to say, though, that for some women, their sexuality actually improves at menopause because, they're not worried about contraception anymore? Maybe the kids have left home. Is it all doom and gloom?
No, probably not all doom and gloom, but I love that question because I'd never thought of it in that way, because of course in our world, we're seeing people that come in with dysfunction. So I'm not seeing people that used to have a problem and now they're good. They're just coming to tell me that things are better.
Yay.
Yeah, exactly. But yeah, from that, because it's not just the physical changes that are occurring. We know it's that biopsychosocial. So if you remove maybe other stressors, and if that was a reason they were having some issues in the bedroom, then of course it could improve their sexual function.
So Heather, let's talk about lubricants, because dryness and some irritation, some thinning, and delicacy of the tissues in around the vulva and the vagina can be an issue, obviously. What advice do you give to women about lubricants, about choosing the right type of lube?
Well, I am a big fan of many different types of lubricants. So really, I tell patients that they should find one that works best with them, and I educate them on the different types. I have a lot of samples too that I can give out, or when they're coming into their sessions, we might try, an Uber Lube silicone base one day, and then try a Desert Harvest aloe based another day, and then do a water based another day if I don't have samples of specific ones, because I don't feel that there's one lubricant that's right for everybody. And but in general, I do say that the silicone lubricants tend to be longer lasting. So, so that's what they might want to consider. But a lot of women, I mean, I'm in California too, so I get a lot of nature-y type of people that don't want anything artificial. So then they may opt for maybe more of a coconut oil or something like that is longer lasting also, but more organic.
So are there any issues with coconut oil? Because I know, it's so rich in vitamin E and, great for skin conditioning generally. Are there any concerns with using that you're aware of in around the vulva or vagina?
Well, I think I have heard tangentially there being reports of maybe an increased infection risk, but I've never have seen it with any of my patients. I mean, I have so many patients that use coconut oil, whether postmenopausal or otherwise, and not had that be attributed to any infection.
Okay, good to know. Good to know. And I suppose the only thing that we need to mention about using oil-based lubricants is, of course, that they're not compatible with condoms.
Correct.
Apparently,
but not so much a concern in postmenopausal women.
well, apparently STDs are rising fastest in.
Good point. Very good point. I'm thinking more of the pregnancy standpoint, but yeah, STD, and that, I mean, I hear that the STDs going through nursing homes, right? So you are 100% correct on that. So that would be a big issue. All oils.
So what, in your work educating other professionals, how do you tell them, how can people start having conversations with their clients, with their patients about sexual health, because we know it's an ADL, we know it's on Maslow's hierarchy of needs, you know, as a basic function of humanity. But I think a lot of folks are still quite embarrassed to bring it up. You know, I remember when I was a baby women's health physio, you know, many years ago, or actually even working in ortho and sports medicine, and you know, you're doing your screening questions and you ask, so any problem with bowel or bladder? And you're like, please say no, please say no, please say no, please say no. You don't have to talk about it. And of course now, you know, all day, every day, it's all that we talk about. But is there a way to kind of open the door to have these discussions with the women that we're working with who are going through menopause, who may think that this is normal and that this is going to be the rest of their life?
Well, I mean, I am just comfortable enough with it that I flat out ask, but you know, maybe it might be better if there's like coming from like an orthopedic perspective and somebody that's not as comfortable with asking. I think, you know, every orthopedic therapist, and of course, like every primary care physician, every gynecologist needs to have a local pelvic floor physical therapist that they can refer to, because it doesn't take that much time to ask the question and send the referral. They're not expected necessarily to provide the treatment for it, although as we know with post-menopause or menopausal women, that like estrogen plus physical therapy does have like a better outcome than using either modality alone. So they'll have some medical management most likely on board as well, if the woman chooses to do that. But, you know, thinking of maybe an orthopedic therapist that's just not as comfortable with that, maybe perhaps just knowing they have a place to refer and they can just ask the question, you know, I noticed you checked this box, you're in menopause. There are many common symptoms of menopause that can affect vulvar, vaginal, you know, and the urinary tract, and that there is actually somebody that can help you, you know, if you have these symptoms. So are you having any symptoms such as bladder leakage or any difficulty with your bowel movements or any pain with intercourse? And I don't know, I think they just need to get comfortable with it. But I know a lot of like primary care providers don't bring it up to their patients. And so, you know, to put that on a physical therapist, however, we tend to have, I'm not going to say better relationships, but we spend more time. Yeah, okay, there you go. We spend more time with our patients. So maybe as a suggestion, if like there's an ortho PT watching this that's just learning about pelvic health, maybe you just don't ask them that on day one. Like maybe, you know, visit 2 or 3 once you sort of, you know, have gotten through they're coming for their hip pain. So maybe like, okay, you know, just while we're sort of looking at like your total wellness, let's also discuss about this stage of life that you're in and how these symptoms are so common, but they and they are like a quote unquote normal part of the aging process, but there are things you can do about it if you feel it's a concern that you want to address. So maybe
I think we're in such a good position as physios, you know, because we can bring together, you know, that orthopedic skill set where we're thinking about hips and spines. We're hopefully skilled, you know, not only in the interviewing process, but also in looking for dermatological issues, maybe any thinning or micro trauma to the tissues, and then to be able to talk about the ergonomics, maybe different positions as well. Do you find, you know, do you use many screening questionnaires? I like the Australian pelvic floor questionnaire. I think that can be quite a useful one. Do you rely on any written questionnaires, or is it just a matter of you sitting down and talking to the woman who's in front of you?
Oh, I definitely use written questionnaires, and they're specific to what the person's diagnosis is that's coming. So if they say they have vulvodynia, then I send like the vulvar pain questionnaire. And we also have like that everybody gets, because just about, I mean, 95% of our patients report some type of pain. So we do see incontinence, but the largest portion of my practice is more centered around pain. So, you know, we have a patient-specific functional questionnaire, I think it's called, but it's just a fill in the blank. And so that could actually go for incontinence as well, you know, and then they just rate 0 to 10 and they fill in the blank. So it's not like a validated sort of, you know, universal measure, but as a clinician, it gives me it tells me right away, like, what are the 3 most important things to this patient? So, you know, if they say, I can't put in a tampon, I can't have sex, then I know, and those are my goals, and they've written them in. I also have used, I kind of go back and forth because I'm still not sure which one I like the best. I use the PISQ-12 pelvic impact symptom questionnaire 12, because that has sexual function questions on it. So that's nice because it can capture something that patients might not realize they can address.
Sure.
I've used the female sexual function index, but we only give that to women if they over the phone are reporting a sexual dysfunction.
Okay.
And yeah, PFDI 20 I use as well, but that doesn't have the sexual. But so yeah, which one do you use? Because that is not one that I have.
Oh, okay. So I'll send it over to you. It's the Australian Pelvic Floor Questionnaire. So it was validated by IUGA in 2012, and it's got questions on bladder symptoms, bowel symptoms, prolapse symptoms, and sexual symptoms.
Oh, perfect.
So it's lovely, and the patient fills it out themselves, and then it kind of just opens the door for conversations, and it's a really nice screening tool. How do you find in California, where you're based, that physicians' attitudes to sexual health, to asking about sexual health, are changing, or that their willingness to refer out to physical therapy is improving at all? Because I think not a lot of physicians are making the connection between sexual dysfunction and physical therapy. What's your experience?
Same experience. And even in this, LA, you might think is so progressive, but I have my handful of physician referrals that are pretty consistent, but I get so many, not necessarily the majority, but a very high percentage of referrals from Google that I then send back to their physicians for,
okay,
the signature that they're okay to come to pelvic PT, that they don't have infections and all those other things that I can't do anything about. But yeah, so, and then it's just, random physician names, but they found us on their own through a Google search.
Which of course, is one of the beauties of this book, and having this book out there for women to access, because like I said, there's a number of different books out there about, working with painful sex and, and overcoming it, hopefully, as well. But I have to say, and I'm not just saying this because you're here, but it's probably the reason that I asked you here, this is probably the best one out there, in my opinion. And for anybody who knows me, they know I'm a book fiend. So I have, this is based on extensive research. But really, I think what I love about this book is it's super practical, excellent illustrations, and just easy to follow. But it's not just vagina centric. You take it all the way through to that mind-body approach, to incorporating exercise and stretches and that whole body well-being. And of course, women, in perimenopause can have issues with overactivity in their pelvic floor too. It's not just an issue for young women or teenage women. What drove you to write the book, Heather?
Well, it was about 2010, and I remember very distinctly, it was 2009, 2010, because I was pregnant with my son at the time, and we had moved to New York City for my husband's fellowship. And I just was getting all these emails from around the world and asking very specific questions about how to self-treat their vulvodynia and their vaginismus. And, that's just something I can't go back and forth on an email about. And you just can't provide care necessarily in that fashion. And it's time consuming as a provider to go through lengthy emails. So I sort of started going back and forth with a couple of people, to a small extent, because I just felt bad. I have a bleeding heart and I want, to help these people that are reaching out that are so distraught. But then it kind of got to the point where I was getting more emails, and I said, I'm actually writing a book, and, it will publish within the next year. And, please, take a look at that when it comes out. But I hadn't actually even started writing the book at that point. But I'm like, okay, I said that I am to this one person, so now I have to write it. Because at the time, there wasn't anything out specific for sexual pain, and that I had come across, and much less something that's just accessible, sort of education wise, that, I think there's books that are 400 pages, and I'm the last thing I know how overwhelming chronic pain is, and I think especially sexual pain is, that the last thing any of my patients ever want to do is to read 400 pages about how to fix their pain. They just want to know,
How?
what's my pain? Like, or I don't even know what's my pain. They just like want to know how to fix it. They don't even care about the background info. A lot of them, you know, like they might ask why, but ultimately like, you know what, it doesn't matter. Like, let's just fix it. So what I thought was going to maybe be like a 20-page, like almost pamphlet, did grow to more because I was trying to incorporate some like mindfulness and the lower extremity stretches to help if there's any like hip or back dysfunction. You know, it became more like 100 pages, but still I thought that was pretty digestible, and it has a lot of photos and graphics, so it's not very text heavy. And I feel like it's something, if someone's motivated, they could like at least look through and see what the program is in a day and feel like, okay, this is.
Yeah, I mean, what I love about it is that it's a graded program, so it's a 4-step plan, but it's very logically laid out. And, you know, I mean, if we're talking, you know, specifically about menopausal health issues, you know, we've talked about how estrogen, you know, is going to direct, obviously, the vulvar and vaginal tissues directly, but it has about 400 different functions in the female body. And it definitely has an effect on muscles and tendons and fascia and connective tissue throughout the body. So, you know, I love that you've got you've got a lovely generalized flexibility program that's, I think, going to improve mobility, but also really help women get back into their bodies again, you know?
Yes.
So they're an active participant in their own healthcare rather than just having a prescription from their doctor or, you know, having something done to them. They actually to run with their own healthcare.
And that is, I'm so glad you mentioned that, because that is the biggest failure that I see in women that say they haven't improved, is they don't have a home program. Like with anything, right? Like I feel like something I learned right away in PT school, that everybody has to have a home program. It's like education and or something physical that they're doing, but they have to have something they're doing at home. Absolutely. To take a passive approach and have therapy done to you is, if they get better, it will take, I don't know, 4 times as long, because, you know, I just don't think that somebody with vaginismus, for example, like if they just have isolated vaginismus, they don't have any hip pain or back pain, it's just very centralized. I mean, there's no reason those people should not be making significant improvements within like 3 to 4 months, if not completely better by 6 to 7. Absolutely. Right? Like if no history of abuse, like if it's just very like, maybe they had a yeast infection when they were a kid. But when I see women and they're like, you know, maybe I do like lots of talks in the community and women will come up to me and they maybe are seeing somebody else and they've been like 1.5 years, 2 years in their treatment for vaginismus. And I'm like, I just don't even understand how it takes that long. Like, I mean, my world record is I like 15 months, you know, not that it can't come back, because if they have hip or back dysfunction, it's not addressed. And I educate all my patients on this. Those are the people that maybe do have to come back for tune-ups every once in a while. But you know, this is whether they're, you know, that's just general women's health, you know, so that ties into menopause too, for sure, that we need to address hip and back dysfunctions, and that a pelvic floor physical therapist or a pelvic health physio cannot just treat the pelvic floor.
No.
So yeah. And that drives me crazy too. And that's what I think, like, okay, you're still having work done to you. You have no home program and they're only doing intravaginal work. Like, this is not a prescription for success.
No, it's not. And I mean, you know, I think, as you're saying, fair, you know, it's a fair point that, you know, people may need tune-ups every now and again, but I mean, we get our cars tuned up, you know, so you know, I think if we've had an issue, I think, you know, that's an active part of maintaining wellness. But I think, you know, that's why I really like the book, is because it is a whole person approach. But again, you're empowering the woman, you know, it's not like you're saying you need to go to a therapist and the therapist will be like a mechanic and just work on you and you just lie there. I think that's such an important point to make, that it's very much, especially when we're talking about sexual health, it is very much a mind-body, you know, approach that you take, that you're really looking at global movement. If someone is experiencing sexual pain at menopause, what's their first step? You know, is it to go get checked out and make sure there's nothing going on from a dermatological point of view? You know, how would you see that evolving, that journey evolving from developing pain to resolving pain?
So if a woman is watching this and she says, oh, I have pain, I should go see a physical therapist, I would say, no, you should see your physician first, because we need to rule out that there are medical causes of your pain. So when you think about menopause, other than the genitourinary symptoms that happen as the decreased hormones that we talked about, there's other like dermatologic conditions. So, we're not the ones that can help medically if someone has a lichen sclerosis, for example. I've identified that in patients where it's been missed by a physician. I don't know, but still, I can't do anything with it, and they ultimately need to start with a physician to rule out they don't have an infection as well. So that they should not go directly to a physical therapist, even if it's a state where you can go directly to a physical therapist. And I don't know how it is in the UK, but if it's only referral based, but for sure they need to be medically cleared before coming to see me.
Yeah. And do you find that, going straight to topical estrogen, or would you encourage trying lubricants and moisturizers first?
I encourage the latter because it's more holistic. So I feel like if you don't need to put extra medication in the mix, then why do it? But I mean, the research has shown that the estrogen plus pelvic floor PT is the best combination. But it kind of depends on how early you catch it too, because is there pain? Is it due to the fact that there's low lubrication, or was that how it started? And then now they've experienced pain, so they have that muscle guarding response that's physical. They have that fear response that's feeding into the muscle response. So maybe all they did need was lubricant, and they're using it, but they're still having pain. That doesn't mean they need estrogen. They might need just a muscle assessment. So, it's an individual choice, and people have their concerns with using hormones, and whether it's topical or oral. So, I say always try to go the most holistic path you can. And if you need to get other things on board, then you have those options and you can work down that treatment pathway.
And I think just even being able to educate women that local topical estrogen is an option, that they don't have to go down oral systemic therapy. If this is the only issue, just sometimes even a short course of topical estrogen combined with education and maybe seeing a physio, that can often be, the boat to get you to the other side. It's not necessarily a lifelong commitment that you have to make.
Yep, exactly.
Yeah. Heather, is there anything else that you would like to, just put out there in terms of clinicians working with women at menopause and sexual health? Is there anything else that we should know that we've missed in this conversation? I feel like we've covered quite a bit.
Let me think a sec. I think we didn't talk specifically about the education component, and I just think that that's really important, because actually just yesterday I have one of my postmenopausal women, and she said that she's was very upset with her gynecologist, because her gynecologist, when she hit menopause, her gynecologist just said use it or lose it as with regards to sex, and gave her no education as to what that means. And she wasn't having pain at the time, right? But then she started to develop pain, and she was like, oh my God, I didn't have sex, I lost it, right? So she was really upset by that. And whereas, and I've educated her, and I've only seen her twice, and she's just like, I wish my gynecologist would have told me that, she wasn't so upset about the use it or lose it. She was upset about the fact that there was no education or follow-up as to what that meant. So she's like, I wish my gynecologist would have told me just what you said, which, I said something along the lines of the changes that occur during menopause, the genitourinary symptoms that change or that happen during menopause, I should say, and how that can impact sexual function, and what you might be able to do to minimize the effects of that, like lubricant, like just even using lubricant. She thought if she would have thought about that, but she had gone 30 years never having used it. It's not even a thought that she would need it.
Just not on her radar. Yeah.
Not on her radar. So I think that the education component is really important. And, I think by the time they're coming to see us, the problem has already occurred. But what can we do? We can write more blogs. We can do more social media, the hashtag menopause symptoms, to get like maybe women that are searching for
Yeah.
answers some
But I
information.
think so, Heather, I mean, I think I was thinking as you were talking, when we actually first met in real life, it was at a gynae cancer course in
Yes.
California. And, we were discussing at that course how many women have gone through cancer treatment who are essentially just handed a set of dilators and
Yes.
told, there you go, no conversation about lubricants, about how to use them properly, about transitioning to a vibrator, So I think that's really an area that as physios, because we have that gift of a little bit more time maybe with the women that we're working with, I think that's one area that we can really kind of step up our game a little bit. But I think this is why having conversations like this is important and putting this information out there, because it's very easy to be critical of physicians, but they don't know what they don't know. If we're not
that's
telling them
true.
that this is what we can do, then I think
Right.
it's our fault as well.
Yeah, and I'm not generally critical of physicians. I'm critical of physicians when I do try to educate them that put it off as something that just can't be helped because it's a normal part of aging.
Oh.
So I'm put off by that. And I know that physicians probably across the world, like, in every country, they don't have a lot of time with their patients. So they might have, we know most physicians will not bring up sexual dysfunction. That women, like 85% of the time, are the ones that have to bring it up. So there's that component that they're not even asking the questions. And women might already have normalized it or think that it's just a normal part of aging. And, as far as, like I said, I love physicians. I'm married to a physician. Like, I have nothing against physicians. But they don't have the time to treat it. So I think there might be some hindrance to even asking the question, because what if they say, are you having any pain with intercourse? This can be normal during menopause, and maybe we can discuss some treatment options. What if they break down crying? And then you're like, oh no, this is going to put me behind. Like, maybe they don't even want to ask the question because they don't want to go down that road, because it just might be opening up a whole can of worms. And especially if they don't have a pelvic floor therapist that they can refer to, or even know that that's an option. I think it might be it's an overwhelming topic to try to deal with. And it's so emotional. And so I think that's my own conjecture a little bit, but I kind of have that feeling like.
Well, I agree with you. So I'm going to say that you're right.
Because, okay, good.
Who doesn't love a little confirmation bias,
Right.
No, I think you're absolutely right. But I think this is also going to be an issue that will be, particularly as we're seeing more and more women. If you think of women in their 50s today compared to women in their 50s 20 years ago, we've got people like Jennifer Aniston and Nigella Lawson, and I'm trying to think, who else is in their 50s now?
50 is so young, yeah.
The closer I get to 50, the younger it seems. But it's really, I think women are going to be demanding better of their healthcare providers. And I think, again, pelvic floor physios can really play a big role with this. But I think it's up to I think every contact counts. So, no matter what your profession, if you are working with women in this health space, I think just to start normalizing the conversation and to realize that there are providers out there, but there are resources like your book out there that women can access and really start to again, to take charge of their own health.
Right. And one thing that's not in my book, which I should add, I think, to a revised version of it, is thinking of partner issues, because we talk about menopause and we've only talked about the issues with the woman. And if their partner is also aging, maybe part of their sexual dysfunction is due to that as well. So I think, keeping in mind the couple, and I've even seen it written as like couple pause, like calling it couple pause, which I think is so great. So not just saying that it's a problem with the woman. Because
I think, in a heterosexual relationship, we know, I think the stats are something like 40% of men in their 40s have some sort of erectile dysfunction. And then that goes up to 50% of men in their 50s, 60% of men in their 60s. So I think that definitely is a part for it. But I also think creating a space for women to have some resources for self-exploration, because I think sexual health starts within, and then then to look at the wider picture, I suppose. So lots to improve upon, but lots that I think is going well for women, in terms of the increasing amount of resources out there. Heather, where's the best place for people to buy your book? Is it through Amazon, or can they buy it directly from you?
So you can get a PDF immediate download on sexwithoutpainbook.com. So that's kind of the easiest thing for people worldwide. It is available on Amazon, but I think when you're ordering it from the UK, there's a pretty high shipping fee if you use Amazon. So Pelvic Relief is a distributor that sells my book in the UK. So you can, if you're listening from there, but other places, yeah, Amazon, and it's also available in ebook format on all digital formats or platforms. So,
and where can people follow you on social media? What are your titles on Insta and Facebook?
Yep. So on Instagram, I am at the Lady Parts PT, and that's also my Twitter handle. So Instagram and Twitter. And on Facebook, I'm under Heather Jeffcoat DPT. And that's for me personally. My female branded practice is called Femina PT, like female, femina.
Lovely.
So you can follow us on Instagram and Twitter at Femina PT, and on Facebook at Femina Physical Therapy.
Fab. Heather, thanks again for joining us. Super informative, lots of pearls of wisdom, as I suspected there would be. And I'm going to encourage, if you haven't got this book already, and you're working with women at menopause, you need to get this book. Heather, thank you again, and all the best.
Thank you. I hope to see you again soon. It's been too long.